As part of the discussion of respiratory pathophysiology, we will now look at one specific condition, asthma. Asthma literally means panting. So here we can see why it's called panting. A patient with asthma probably is struggling to expire air and having difficulty breathing, in other words. Well, it's another obstructive pulmonary disease, which is basically where a patient has an inability or difficulty releasing air from the lungs. And that's because of the inflammation, mucus secretion, and inflammatory reaction, and the fluids that are going to be added to the secretion of mucus, which is already in greater amounts than normal. All right, what causes asthma? Well, many agents are connected to asthma: airborne pollutants, allergens such as dander, or gastroesophageal reflux disease, where the gastric content would escape through the esophagus and enter the airway and cause irritation locally. Now, all of this would cause inflammation of the bronchial mucosa. Bronchi, part of the airway, mucosa, innermost lining of the airway. Now, there is inflammation in the inner wall of the airway, and inflammation, and the consequences are not new to you at this point, but that is what is causing asthma here. Now, because of this new situation, that is inflammation of the airway, there is bronchial hyporesponsiveness. Okay, mucus glands are activated. For example, smooth muscle activation causing constriction. This is basically through spasm that it triggers constriction of these small airways and variable airflow obstruction. However, this can be totally reversible. Okay, unlike COPD, where it's not fully reversible, asthma can be fully reversed. Now, one half of all cases start during childhood, and it's a genetic disorder. However, there are hundreds of genes linked to this, but not a single one. Okay, and environmental agents, like you saw here, may also be able to trigger asthma. Okay, so with this, we can organize the response related to asthma in the early part and the later part. Early part is like immediate response. Okay, for the reason allergen, the immune system is involved. This is asthma is considered as type 1 hypersensitivity. Okay. Now, what does it involve in the early asthmatic response? Okay, so one has been exposed to a certain agent, and how does that person react? Well, it's listed here: episodic attacks of bronchospasm. Okay, the smooth muscle contraction locally, bronchial inflammation, mucosal edema because of the inflammation, and the fluid accumulation, and then increased mucus production. This is another interesting fact. Mucus production and the fluid due to inflammation. It's a combination that leads to a lot of fluid locally and causing edema and occlusion. Now, let's look at the mechanisms involved in causing these changes. All right, antigen exposure. Antigen is the allergen we're thinking about here. It's exposed to bronchial mucosa. Now, that activates the antigen-presenting cells to process the antigen and present it to the CD4 cells. Okay, APCs processing the antigen and presenting it to CD4 cells, and activated CD4 cells would release specific cytokines. IL-4, IL-5 are the two I have listed, but there are many more cytokines released, and there are other effects that are not so critical for us to deal with. So here, IL-4 would activate B cell as B cell activation, which then specifically releases IgE. So IgE antibody would bind to mast cells and basophils, and that leads to a degranulation. That is, stored chemical mediators are released, and now those could be histamine, leukotrienes, and cytokines. All right, so inflammatory response is what histamine typically triggers. So you're looking at vasodilation, plus increased capillary permeability, and all of this leads to mucosal edema, bronchospasm, and increased mucus secretion. Okay, we looked at those here, and those are all possible. Now, damage to epithelial lining. Okay, the irritant like the antigen or the allergen could also damage the epithelial lining independently, and that could lead to thickening of epithelial basement membrane that could decrease the size of the lumen. All right, or the inflammatory response, because it's chronic and continuous, that could also cause damage to epithelial lining. All right, now let's talk about IL-5. IL-5 activates eosinophils. Okay, that's again going to increase bronchial hyperresponsiveness, fibroblast proliferation. So this is where there is too much fiber. That's how it would be fibrosis kind of effect, fibroblast proliferation, epithelial injury, and airway scarring. Okay, fibrous tissue buildup is the reason for airway scarring. So we talk about IL-5 using eosinophil, IL-4 using the B cell, and then ultimately mast cell and basophil. All right, so that is one situation. Here it's just an illustration of what's all going on. Degranulation of mast cell, meaning the granules containing these chemical mediators are released in response to IgE binding to mast cell. And buildup of mucus here, alveoli being larger than normal. Again, buildup of air is the reason for that mucus plug shown here in again. Now, the acute asthmatic response is summarized just like we already went over. Antigen entry to airway. Okay, follow the numbers here. Okay, this is the airway, by the way. You're looking at the pseudostratified ciliated columnar epithelium, goblet cells here. They're the ones that secrete mucus. Now, let's take a look at it. Antigen entry to the airway, and now antigen binding to the receptor on the mast cell, and we also have to think about what happens next. You have the mediator effects. Let's talk about IgE that's around, may bind to it. So the presence of IgE is critical. Whether IgE was already there or synthesized depends on whether the body was exposed to antigen before or not. See, if antigen was exposed to the body before, then there are memory cells which can trigger the response immediately, like here. Okay, the 2 leads to 3, where you had IgE being released immediately, and that binds to the mast cell and release of these chemical mediators. Those mediators would cause a number of things. One is the capillary permeability being increased, so leakage of fluid. Another one is the recruitment of leukocytes. All right, so that is mediator effects. Now let's talk about 4. This is where you're talking about dendritic cells. These are antigen presenting cells detecting the antigen, presenting it to the helper T cells. Helper T cells release IL-4 once they're activated. IL-4 activates the B cell. B cell produces IgE. IgE is the one that binds to mast cell. Now, another effect is the release of IL-5. IL-5 would activate eosinophil. It triggers the release of another set of chemicals. Okay, so you're talking about neutrophil activation, mediator effect. So basically, phagocytes are activated, capillary leakage is activated, is increased. So inflammation response is what you typically expect at this point. Another thing that you notice is epithelial injury. Okay, that would trigger fibroblasts, which would then add more fibrous scar tissue locally, causing thickness of the epithelium. Again, narrowing the space here. Buildup of mucus is another thing. Okay, late asthmatic response is where you're talking about so many hours have lapsed. Okay, and after the early response is the late response, obviously. What's going on? Chemotactic recruitment of lymphocytes, eosinophils, neutrophils, prolonged smooth muscle contraction, airway scarring, increased bronchial hyperresponsiveness. It's a vicious cycle. Impaired mucociliary function, where cilia are not able to clear mucus from the area, with accumulation of mucus and cellular debris forming plugs in the airways. Airway remodeling, if left untreated. Remodeling is where there are new fibroblasts being activated to secrete fibers, then thickening of the area locally. So airway remodeling, if left untreated, air trapping within the lungs, hyperinflation, due to obstructions, and increased work of breathing and hypoxemia. All right, so these are not new to you. You have seen it before in COPD, and that's the same thing that's happening here as well. Okay, so the same thing is summarized here. Allergen or irritant exposure, immune activation. As I mentioned, there are a number of interleukin secreted in response to CD4 activation. All right, mast cell degranulation, which releases IL-4, IL-5, B cell activation ultimately may be the cause of IgE production and mast cell granulation, that degranulation in that manner, or if it was previously exposed, direct activation of mast cell and vasoactive mediators are released, vasodilation, increased capillary permeability, and bronchospasm, vascular congestion, mucus secretion, impaired mucociliary function, increased contractile response of bronchial smooth muscle, thickening of airway walls, fibrosis and increased muscle thickness contributes to airway remodeling. So all of this was discussed before, and bronchial hyperresponsiveness and airway obstruction. Now, the other place here, you have chemotactic mediators, cellular infiltration like the neutrophils, lymphocytes, eosinophils, autonomic dysregulation, now causing all these changes, release of toxic neuropeptides, epithelial desquamation, and fibrosis. Okay, desquamation is the change in the epithelial nature from, let's say, the pseudostratified nature to squamous nature, thin, flat cells instead of tall, cylindrical, columnar cells. Clinical manifestations of asthma. Well, when there is no irritation, things can be calm and asymptomatic, whereas when there is exposure to the allergen, there may be chest constriction, expiratory wheezing, okay, very typical of asthma, dyspnea, and non-productive cough, okay, prolonged expiration, tachycardia, and tachypnea, okay, faster breathing rate, faster heart rate. These are compensatory mechanisms. All right, that's what we have for asthma. We'll stop here. Thank you.